holding.
So Dr. Snyder, when you get referred a patient with endometriosis, one of the things that you look for in the office exam is tethering. What is tethering, and tell us about that?
Tethering is where the endometrial nodule is actually growing from outside on the serosal surface inside to the mucosa, and what it does is that it creates sort of a fixed point. So when you insufflate the air there, you see a little puckering of the rectal mucosa, and it doesn't stay in one place. Actually, it stays in one place when it moves. It doesn't have the normal peristaltic pattern of the rest of the rectum.
And so what is the significance of a patient that does have tethering when you evaluate them? What does that get you concerned about?
It reveals a fairly deep nodule in the cul-de-sac, and usually requires bowel resection or excision of the nodule for cure.
Go ahead, say that.
All right, here's your vaginal cuff right here.
Okay.
Because the endometriotic nodule from the bowel was right into the rectovaginal septum. So when we were freeing that, the vaginal wall was so thin on the apex that we had to go ahead and enter it. Now all we're doing is just closing the vaginal cuff, and you can see the whole thing there. Suture, please.
It's either that or leave.
That's right. Sometimes if it's infection, yeah, exactly.
There's no reason for that.
Yeah. And sometimes if it's infection, and like you said earlier, some people will leave some of the vaginal cuff open. And they used to do that a lot more in older days when they used to have bad infection. I haven't seen myself a bad vaginal infection where we have pus and stuff. We leave the cuff open. We don't do that anymore.
Right.
Just like your drain, and you guys used to put a lot of those drains in the Blake drain and JP drain, and you guys don't do that anymore, right, Mike?
Yeah.
Okay, so here we have done a rectosigmoid resection, long anterior resection.
Where the hell are you?
And this patient had bilateral ureteral stents placed so we could help identify the ureters intraoperatively. Is there anything that's different about the position of the ureters in a patient with endometriosis?
Yeah, actually the ureters, almost, if they're in extensive endometriosis, you rarely ever see them in the normal anatomy. Most of the time you see them almost hugging your bowel, if it's a nodule on both sides, where you never even think that the ureter would be in that place.
So would it be safe to say for all of your endometriosis cases you probably place stents preoperatively to help identify the ureters?
Absolutely. I think there's no question in my mind when you got extensive endo, because not only just identified, but most of the time there are nodularities of endometriosis on the ureter and next to the uterus. And then if you don't have the stent, there's a good chance that you'll end up leaving some endometriosis by the ureter. That's not just identification, but I think it's essential that you get all the disease out, and that having the stent in place certainly makes it more safer.
And how do you identify endometriosis intraoperatively? Does it look like a blue nodule? Is it by feel? What is it that, or does it just take years of experience?
Right. Actually, endometriosis surgery is what we say feel surgery, feel and look surgery. You can't just look at the endometriosis and think you got it. Because as I was telling you earlier, endometriosis is like iceberg. What you see on the surface is 2/3 deeper. And if you just happen to just skim the surface, you've left majority of the disease.
Let's just start getting the
Stapler.
stapler.
Okay. Back to work.
Just above the rectovaginal septum. And this is the vaginal side, the inferior portion, and this is the superior portion of the rectosigmoid colon.
Okay, show me that again.
So essentially, this is the inferior portion, and you can see the endometriotic nodule. This huge nodule right here, and you can see it protruding. But unfortunately, 95% of the time, colonoscopies are almost normal. I mean, you can see how big nodule it is. The colonoscopy was normal.
Right.
You can see that.
Interesting. Impressive, actually.
The difference between cancer and endometriosis, cancer start here, go outward.
Right.
Endometriosis start outside and go inward. So that's one of the reasons even a severe endometriosis you may not
Can
see.
be missed with colonoscopy. Okay. So from the outside, show me how it looks.
Yeah, so essentially when you're looking at this nodule,
that's the bowel wall.
that's the bowel wall outside.
Okay. From the
How many
outside.
copies of those pictures?
This is the nodule. And then from the outside, once I cut it,
Uh-huh.
You can see this thing, it's like iceberg. You see, it looks like it's only from here to here, but you actually see it, it goes all the way down. So it's from here, not just what it looks like to be there.
All right.
So that's why it's like an iceberg. And she had rectal bleed cyclically. When she used to have regular cycles, she would have bleeding in the rectum. So that's
You want to close the vagina here real quick?